So, how do we get to hypertension as your main area of focus right now?
Yeah, my interest in hypertension specifically started when I was in training at University of Southern California, and that was at a time where comorbidities were becoming a very high area of focus within the multiple sclerosis community, where some large cohort studies, meaning these large databases that were available in like Canada and nationalized healthcare or large insurance databases were indicating that people who had a diagnosis of multiple sclerosis and a diagnosis of a vascular comorbidity had worse disability than people who had multiple sclerosis alone. And that could include many things, whether it was smoking or high blood pressure, high cholesterol, diabetes, things like that across all of those had some of that evidence. And so we wanted to look at that specifically in Hispanic Americans. And this data got published in 2021 in Multiple Sclerosis Journal out of the USC in Los Angeles location of the ARMS registry. And what we looked at was overall disability levels that we measured as basically the need of using a walking assistant. So we were looking at physical disability. And we looked at all of those different diagnoses in people, Hispanic Americans with multiple sclerosis in the Los Angeles area. And what we found was that hypertension specifically was associated with worse ambulatory disability. About two times the odds of having to use a cane for individuals who had high blood pressure and MS as opposed to the people who had MS but not high blood pressure. And we also looked at diabetes and high cholesterol and smoking, and those didn't have as strong of an association. So that's where kind of we focused in on hypertension. And one of the interesting findings of that paper was that we went back and looked at all of these individuals' actual blood pressure readings. So we didn't just look at whether or not they had a diagnosis of high blood pressure. We actually looked at what is their blood pressure right now. And we found two interesting things there. One, that the level of hypertension control seems to be a predictor of how disabled they were. So it wasn't just anyone with a diagnosis of hypertension, it was specifically the people with uncontrolled hypertension or stage 2 hypertension, which means systolic blood pressures over 140 or diastolic blood pressures over 90 that really drove those associations with over 3 times odds of having uh, that ambulatory disability. And while we had that, we also looked at who could we diagnose with hypertension just by vital signs, like what was their actual blood pressure. And what we found was that when we looked at the diagnostic codes and or patient surveys, 7% of that population said, "Hey, I have hypertension," or their chart said, "Hey, this person has hypertension." When we looked at the vital signs, 27% of individuals actually had diagnostic vital signs of hypertension. So there seems to be this gap. And that's where my interest in hypertension awareness actually came in of like, hey, if hypertension is treatable and hypertension is not being fully diagnosed in these individuals, that's very actionable. That's a care gap that is cheap and easy to say, hey, we need to diagnose more hypertension and treat more hypertension, and maybe we can actually intervene on some of this disability.